Hello everyone, in this video we will talk about beta blockers. So what is this beta blocker? Beta blocker, as the name suggests, it blocks the beta receptors, and these beta receptors are basically part of the sympathetic nervous system. Okay, so sympathetic nervous system releases epinephrine and norepinephrine, and this epinephrine and norepinephrine act on alpha and beta receptors. So if these beta receptors are blocked, then what are the effects which are seen? We will talk today. So first of all, for understanding after blocking what are the effects, we should know that what are the physiological effects, isn't it? So we have different types of beta receptors. We have beta 1, beta 2 and beta 3 receptors, and when these are stimulated we have different types of effects. So let us see what are the effects, and when these effects will be blocked, what will be the response, what will happen in the body, and for which purpose these beta blockers are being used. So first is beta 1 receptors. Beta 1 receptors are present in heart and juxtaglomerular cells in kidney. These juxtaglomerular cells produce renin. Where in heart it is present? In heart we have SA node, AV node, and these are conducting tissues. Actually these are known as autorhythmic cells. SA node is the pacemaker, so it generates the impulses which is important for the heart rate. Okay, then here conduction is taking place, so AV node also has these beta 1 receptors, and again they are present in atria and ventricles. Okay, so these are contractile cells. So stimulation of beta 1 receptors will be responsible for pacemaker activity, AV node, so conduction, and also for the contractile activity of atria and ventricle. So if this beta 1 receptors are stimulated and JG cells are stimulated, what will be the effects of stimulation? Effects will be increase in the pacemaker activity, so that is going to increase the heart rate. Okay, stimulation I am talking, not blocking. Increase the heart rate, increase the conductivity, okay, increase the contractility, right? And when increase in heart rate and increase in contractility happens, that is going to increase the cardiac output. Okay, because cardiac output is heart rate into stroke volume. So contractility increases, so that means stroke volume is going to increase, and heart rate and contractility increase will lead to increase in the cardiac output. Okay, then increase in renin secretion, it is going to convert angiotensinogen to angiotensin 1, and finally this angiotensin 1 is going to be converted to angiotensin 2. Okay, so here renin is acting, and this angiotensin 2 ultimately it increases the blood pressure, it causes vasoconstriction, it causes fluid retention, and it increases the blood pressure. So increase in cardiac output, that also increases the blood pressure, and this angiotensin 2 also increases the blood pressure. So end result is also increase in the blood pressure. Okay, now if these beta receptors, beta 1 receptors are blocked, we have seen that these are the physiological effects. So if they are blocked, what will be the effect? Opposite. Okay, so there will be decrease in heart rate, decrease in conductivity, decrease in contractility, okay, and decrease in angiotensin 2 formation. So you see, this is going to ultimately decrease the blood pressure. Okay, so yes, beta blockers are used to decrease the blood pressure. They are used in hypertension. Okay, not the first line drugs now, but yes, some cases, compelling cases, they are still used. Okay, so decreased blood pressure. What will be the other uses based on this? Can we find out? Yes, so they are ultimately decreasing the oxygen demand of the heart. Okay, we have seen in the angina video that oxygen demand depends on heart rate, contractility, and the wall stress. So if heart rate and contractility are decreased, they can be used in angina. Yes, they are used in prophylaxis of stable angina. Okay, then they are also used post MI. Okay, post myocardial infarction. Then because they are decreasing the effect on the SA node, they are also decreasing the automaticity. Okay, so automaticity is the ability to generate automatic impulse, so that is also decreasing, and because of that they are used in arrhythmias, right? So you see, so many uses for the heart are there. Then because of decrease in oxygen demand, and also because they decrease the effect of excessive sympathetic activity on the heart. See, when there is excessive sympathetic activity on the heart, there is left ventricular remodeling. So there is hypertrophy of the heart and there is decrease in the apoptosis of the cells. Cells proliferate more and die less. Okay, so when that is happening, it leads to left ventricular hypertrophy, and in case of congestive heart failure, ultimately it is very harmful. Okay, so this decreased remodeling of the heart can occur if we block this beta 1 receptor. So that is why beta blockers are also used in congestive heart failure. Okay, now they are not used in decompensated. That means when the compensatory mechanisms which are stimulating, which are basically supporting the activity of the heart, when they are working fine, then this beta blockers are used. But in acute heart failure, in decompensated heart failure, where now the heart contraction is not happening properly, we don't use this because they are going to decrease the contractility. So remember, please, not used in acute left ventricular failure or decompensated heart failure, but in chronic CHF they are used to decrease the effects of remodeling. Okay, so that is another thing. Then they are used in HOCM. So because of this decreased contractility, they are also used in HOCM, that is hypertrophic obstructive cardiomyopathy. In HOCM, actually there is a hypertrophy of an area, small area, such that when the heart contracts much more forcefully, then it blocks the outflow of the blood from the heart. Okay, so blood doesn't flow out of the heart, this decreases the cardiac output. So it is opposite, like when the heart is contracting more forcefully, there is decrease in the cardiac output because of increase in the block. So beta blockers, by decreasing this contractility, they ensure that heart is not contracting that much forcefully and that block is not increased. So they are used in HOCM as well. Then because of this, they are also used in dissecting aortic aneurysm. Okay, so again in this we need decreased heart contractility so that the pressure on the walls of the aorta is less. When pressure is more, then the blood will flow through the dissection. We don't want that, right? So this decreases the pressure on the walls of the aorta, and also the pressure on the walls of the aorta increases the rupture as well. Okay, so we don't want that. So in that case also there is beta blockers which are used. So many uses are there based on the activity of the heart only, right? And decreased BP, the hypertension, you see, that will also be in effect because beta 1 blockage is decreasing the production of renin, and we have seen that decreased angiotensin 2 formation will also lead to decrease in BP. So this one, it is used because of the effect on kidney as well. Rest, you see, main use is on the heart in angina, post-MI, for the arrhythmias, for congestive heart failure, for HOCM, dissecting aortic aneurysm. So many uses. So these are known as cardiac uses of beta blockers, right? Moving on to the next effects, the main part for which beta blockers are used that we have already discussed. Now we need to know other as well, because there are certain extracardiac uses of beta blockers and for their side effects and contraindications. So first we will discuss block and use, and contraindications and side effects we can easily understand if we know this, that what are the effects. Okay, so other things for which it is for which beta blockers act are these, right? So we'll see what are the physiological effects are. First is on ciliary body. Actually beta 2 stimulation leads to production of aqueous humor, increased aqueous humor formation because of beta 2 receptors present on ciliary body in the eye. Okay, so if aqueous humor is too much, there is increase in the pressure in the eyes, right? Like fluid is accumulating, so there is increase in the pressure. So because of this, beta blockers are used in open angle glaucoma. Open angle glaucoma. This we'll discuss in detail when we talk about the drugs on the of the glaucoma. Okay, open angle glaucoma is basically normal aqueous humor is being produced, but there is some problem in the channel through which the aqueous humor flows back. See, for any fluid on the body, there is incoming, there is synthesis happening, and there is some excretory pathways there. So in the eye also, aqueous humor is being produced, and then it is being taken away by the UV scleral outflow. So in this UV scleral outflow, suppose it is blocked, okay, suppose there is some degeneration and the aqueous humor is not able to flow through that, then what is going to happen? This aqueous humor is going to accumulate in the eye. So we are not functioning to increase the aqueous humor outflow with beta blockers. We are decreasing the aqueous humor production, because beta 2 stimulation leads to increased production of aqueous humor, right? Next, in the blood vessels. In the blood vessels, beta 2 stimulation leads to vasodilation. Okay, so if I block this, what will be the effect? There will be vasoconstriction, and where it will be in the arterioles, okay, as well as in the veins. Okay, so both for these it is used. What are the uses? So for arterial dilation, it will increase, basically by vasodilation it is increasing the blood flow. So if we block this, there will be decrease in blood flow. So it is used in prophylaxis of migraine. Okay, migraine prophylaxis. So that is because it induces the vasoconstriction, that is decrease in blood supply in the brain vessels. Okay, meningeal vessels it decreases. So there is decrease in pressure inside the brain. Okay, and so that is for migraine prophylaxis. So why migraine prophylaxis? Because of vasoconstriction. It is causing vasoconstriction. Stimulation effect is vasodilation. If we block it, there will be vasoconstriction. So it is used for migraine prophylaxis. Okay. Then for veins, portal hypertension. Portal hypertension it is used. What happens in portal hypertension? There are too many big veins are there. Okay. So it's like they are dilated veins because of increase in pressure in the veins. Now, there are high chances of rupture of these veins. So, if these veins are constricted, plus what is happening, you see there is decrease in the contractility, so there is decrease in the blood pressure. So, that is also going to decrease the pressure, right? So, ultimately the decrease in the pressure will prevent the rupture of the walls of these veins. Okay, and that is the main problem in portal hypertension. What happens if these rupture? There can be massive bleeding. Okay, so in portal hypertension, it is used for prophylaxis, especially in people whom till now there has not been any rupture of the vessels or any rupture of the veins. Okay, so that is prophylaxis in portal hypertension. Then bronchus, what is the effect? It causes bronchodilation. Bronchodilation. See, it is easy to remember all these effects of beta 2 stimulation if you remember that it is for fight and flight reaction. Okay, fight and flight reaction, what do you want? Your heart should work more so that it generates more blood pressure and you are able to run more, so there is skeletal muscle increased activity. All this increased activity should be supplied by increased blood flow, so there is vasodilation. Then while you are running, fight and flight, right, your airway should not be constricted. Air should flow properly within the lungs, right? So there is bronchodilation, right? Similarly, others like you don't want to go to toilet during this fight and flight reaction, okay, like time out. No, nobody wants that, right? So there is urinary bladder relaxation by this beta 2 receptor stimulation. Okay, it should not contract during that time, right? Then liver, it leads to glycogenolysis, that means breakdown of the glycogen takes place so that adequate amount of glucose is available for the body to use during this stressful fight and flight reaction. Okay, so if you remember that fight and flight reaction, then you will be able to tell what are the effects of this beta 2 stimulation, right? So yes, we were talking about bronchus, so there is bronchodilation. Bronchodilation, if that is blocked, what will be the effect? There will be bronchospasm. Okay, so bronchoconstriction we can say. So narrowing of the bronchus is going to occur. Okay, then liver, what is the effect? There is glycogenolysis. Glycogen breakdown is going to occur, and this not only occurs in liver, it occurs in heart and skeletal muscle as well. Glycogenolysis, so that the breakdown of glycogen occurs and cells are able to utilize glucose which is generated by the breakdown of glycogen. So if we block this, what is going to happen? glucose is not going to increase, right? Glucose levels may be down, glycogenolysis is not occurring, okay? Then islet cells in beta 2 receptors, okay? Islet cells are present in the pancreas. So these beta 2 cell stimulation in islet cells releases insulin, okay? It releases insulin. Yeah, this is little bit different from the fight and flight reaction, that why it is releasing insulin. But in fight and flight reaction, alpha receptors are also stimulated, and when these are stimulated, they decrease the insulin secretion. Okay, beta 2 stimulation increases the insulin secretion. So here insulin secretion is going to be decreased when we block that effect, right? Before we move on to beta 3, there is another effect that is in skeletal muscles. Skeletal muscles, muscle activity is also increasing. Muscle activity is increasing, and when this muscle activity increases too much, like suppose during exams when you are too much stressed, what happens that it can lead to tremors. Okay, these are known as like adrenergically mediated tremors. Because of increased adrenaline, tremors are there. Okay, and they can happen in sometimes like excessive tremors can happen even in resting condition. In that case, we use this beta blocker. So that is known as essential tremors. Okay, essential tremors. So beta blockers are used for this essential tremors. Okay, essential tremors. They are also used for anxiety, because in anxiety there is increase in the bodily responses, and these tremors also happen due to increase in anxiety. So when we use the beta blockers, actually it blocks these peripheral effects of anxiety. That means the manifestations of anxiety which is happening, that is the person starts sweating, palpitations are going to occur, tremors are going to occur, okay, heart is going to beat too much. So when we block these manifestations of anxiety, how anxiety person feels anxiety, then we are basically the person feels that anxiety is reducing even though it is generated mentally, but blocking the manifestation, the person feels anxiety is reducing and automatically he calms down, right? So that is why beta blockers are also used in anxiety. Then you see, by blocking this beta 1 and beta 2 effects, you are basically blocking the effect of the sympathetic activity, right? So even when epinephrine and norepinephrine are released, they are not going to act on these beta receptors. So we say that it is blocking the effects of the sympathetic activity, blocking the effects of sympathetic activity. And because of this, it is used in thyrotoxicosis, and also preoperatively. If we want to operate on the thyroid for hyperthyroid status, then we give antithyroid drugs, but antithyroid drugs take some time to act. So in the meantime, these beta blockers are given to see that the effects of thyroid hormone are not that much, because it also has effects with increased sympathetic activity that is blocked by these beta receptors, these beta blockers. Okay. Finally, beta 3 receptors are the ones which are causing lipolysis, breakdown of the lipids. Okay. Now, if this lipolysis is blocked, then there will be increase in the triglyceride levels and increase in the LDL levels. Okay, not used for that, but yes, these are the effects if we are going to block. Okay, so let us summarize that where it is being used, and then we will see that based on these effects, what are the adverse effects and contraindications, right? So mainly if you see, the use is for the heart. Okay, so that is known as cardiac uses, and there are certain other uses that is for the other extracardiac uses. Okay, so let us see what are the cardiac uses. One we will summarize. Okay, so uses I'll just write here, summarize. Okay, you can think about it while we are talking. First is CHF, right? Not in decompensated CHF, not in acute heart failure. Okay, so that you have to remember. In fact, that is the contraindication. Let us write here adverse effect and contraindications. Okay, so first contraindication is decompensated heart failure. Okay, CHF it is used. Then it is used in angina, that too in stable angina, and for the prophylaxis in unstable angina. But again, it is not used in vasospastic angina, or what is known as Prince-Metal angina. Why? Because vasospastic angina, we have seen in the video on anti-anginal drugs that the cause of that is vasoconstriction. Okay, coronary blood flow is decreasing due to constriction of the blood vessels. So if we give that, see, blocking them, it is only causing vasoconstriction, blocking the beta receptors. We said main effect is vasodilation. You block it, you will get vasoconstriction. So vasospastic angina, it is occurring due to vasoconstriction. Do you want to give beta blockers here? No, it will cause more vasoconstriction, right? So it is used in here, then it is used post MI, right? Then it is used in HOCM, right? Arrhythmias, what kind of arrhythmias it will use? We have not discussed that. It is used in extrasystoles, okay, because it can happen due to increased automaticity. Then we have supraventricular tachycardias to decrease ventricular rate in atrial flutter and atrial fibrillation. Okay, why? Because it is decreasing the conductivity. So whatever impulses are being generated, the conduction of those impulses will be less in the ventricle. So it is used to decrease the ventricular rate. Okay, so this is ventricular rate in AF and AFL, atrial flutter and atrial fibrillation. Okay, then what else? It is used in aortic aneurysm, dissecting aortic aneurysm. Okay, and it is used to decrease the blood pressure. Okay, so these are the main uses of the beta blockers. Now moving on to the uses due to the action on the blood vessels. What are the uses? That is portal hypertension prophylaxis. Okay, then we have the migraine prophylaxis. Okay, then other use is to block the sympathetic activity, blocking of the sympathetic activity. So that is for use in the essential tremors, anxiety, okay, and thyrotoxicosis. Okay, it is also used in pheochromocytoma. Pheochromocytoma, again, main problem is increase in the secretion of epinephrine and norepinephrine. So pheochromocytoma also, but in pheochromocytoma we want the alpha receptor block as well. Okay, because alpha receptor activity also increases too much because of increase in this epinephrine and norepinephrine. So we have to block that as well. Then only beta receptors we have to give, because otherwise, if too much alpha receptor activity causes vasoconstriction. So this can lead to very high blood pressure. Okay, so that is very dangerous. So in pheochromocytoma we have to block both, that is the alpha receptor and beta receptor activity. Okay, then we saw that it is also used in, here we will write, open angle glaucoma. Okay, so many uses of beta blockers, right? Now, adverse effects and contraindications. See, if you know these effects, you can tell about that. So I told you that we will not use in decompensated heart failure, we will not use in vasospastic angina, we will not use in case of sick sinus syndrome, sick sinus. Okay, why sick sinus? There will be bradycardia. Okay, sinus is sick, that is SA node is sick, so there will be bradycardia. Now beta blockers are already decreasing the heart rate, so we don't want to give in sick sinus syndrome. Then we will not give contraindication. So understand, I am talking about the side effects as well here. We will not give in AV block. Why? Because in AV block, again, already there is decrease in the conductivity. Now you are further decreasing the conductivity, right? Then they should not be clubbed with non-DHP calcium channel blocker. Don't give along with that, because these non-DHP calcium channel blockers also act on the heart. They decrease the heart rate, they decrease the conductivity. So we don't want their actions to combine. Both are acting by the same way. So ultimately it will lead to too much decrease in heart rate and too much decrease in conductivity. That we don't want, right? Then what are the other effects which can lead to adverse effects? Okay, so you see this bronchospasm, very important. Okay, now in diseases like asthma and COPD, already the person is suffering from lung diseases, asthma, already there is bronchoconstriction, and you are giving beta blockers, what will happen? It can be dangerous. Too much bronchoconstriction will happen, right? So they are contraindicated in asthmatics. Okay. Then what else? You see here, what is happening? Yes, glucose is decreasing, insulin is decreasing. So it is like insulin is decreasing, it will lead to increased glucose levels. But here it is decreasing the glucose. Okay, so what is the ultimate effect? Yes, all these effects are there. And one more effect. Actually, because we have blocked the sympathetic activity, now whenever in our body there is decrease in the glucose levels, whenever there is decrease in the glucose levels in our body, then our body, there is activation of the sympathetic activity, so that there is palpitation, there is nervousness, there is sweating. Okay, now this tells our body that yes, hypoglycemia is occurring. And if hypoglycemia is occurring, then we should eat something, and it is dangerous. Hypoglycemia is really dangerous, because hypoglycemia to the brain, that means the nerve cells are not going to utilize glucose, and ultimately there will be decreased ATP production. Okay, so it is dangerous. Now in beta blockers, if we give, there is decrease in the sympathetic activity effects. We are blocking that effect. Sympathetic activity effects are blocked. So what we get is hypoglycemia unawareness. Okay, very important. Hypoglycemia unawareness, except sweating, because sweating is mediated by sympathetic cholinergic fibers. Understanding? Here we are blocking the effects of beta effects, right? So we get hypoglycemia unawareness, and because of this, the beta blockers are best avoided in diabetics. Don't use in diabetics, right? That is another thing. Then what are the other effects? Yes, here you see that they are causing the abnormal lipid profile. So in these we have to be careful that it is causing abnormal lipid profile. Now you see it is being used for heart diseases. Suppose it's a ischemic heart disease patient which occurs due to abnormal lipid profile, and these beta blockers are further causing abnormal lipid profile. So what to do? Yes, we know the effects of all this, we know the side effects. So now we need to know what are the various beta blockers, because there will be some beta blockers, there are in fact some beta blockers which do not cause all this thing, right? If we are using for the heart, we use cardio-selective beta blockers. That means the beta blockers which act on beta 1 receptors. Beta 1 receptors, where are they present? In the heart, right? And on the JG cells, nowhere else. Heart and JG cells. So we will use cardio-selective beta blockers, that is beta 1 selective beta blockers. So these effects, especially this, the lipid profile, especially in ischemic heart disease, we don't want it to deteriorate, right? So let us see what are the various beta blockers now. So beta blockers are of different types. We have non-selective beta blockers and selective beta blockers, and some beta blockers are there which have some additional activity as well. Okay, so they have some additional vasodilator activity. Then we have some beta blockers which have more membrane stabilizing activity. Membrane stabilizing means what? Actually, the potential, the membrane potential is stabilized. We have seen that beta blockers are used in arrhythmia. Okay, so we have different types of beta blockers with different activity, and we need to know that, because as you have seen the side effect profile of these beta blockers, it is huge, right? Even though they are well tolerated drug, actually they are quite well tolerated drugs, but when side effects happen, they are huge and they can affect the pathophysiology of other diseases. So we need to choose which beta blockers to use, right? So we need to know various beta blockers. So we have non-selective beta blockers, okay? So that means they will block all types of receptors, beta 1, beta 2 receptors. Okay, so what are these non-selective beta blockers? Simply remember that beta blocker name is starting from O to Z, that is non-selective. Okay, so we have here propranolol, okay, pindolol, timolol, All are ending in lol. All beta blockers end in lol. Okay. Sotalol, one we will discuss. Okay, so that is non-selective. Then we have selective beta blockers. Selective beta blockers, that is, these are beta 1 selective, that is cardio selective beta blockers. So what are these? All from A to N. Okay, so what are these? I'll give you another mnemonic as well. A beam, and all from A to N. Both you should remember because we will see. Okay, so here we have atenolol, ace-butalol. Okay, B, we have ace-butalol, this A. B is bisoprolol, bitaxolol, another B is bitaxolol. Okay, then E is esmolol, then A I have written ace-butalol, and M is metoprolol. Okay, so all these are cardio selective. Others are also there because I told you A to N. So there are celiprolol, okay, and carvedilol. So these are all beta 1 selective. Now there are certain exceptions in this that you need to remember. One, N I have written here. So there is nebivolol. Okay, nebivolol. But one N here also comes, nadolol. Okay, nadolol is here. Nebivolol is in cardio selective. Okay, now other exceptions, this carvedilol. Carvedilol is cardio selective, but in actuality it is having beta 1 plus beta 2 plus alpha blocker activity. Okay, so it is also blocking alpha receptors. Okay, why we are telling it cardio selective is because this carvedilol has antioxidant property, and it helps in that left ventricular remodeling I was telling you, right? So it helps in that, it prevents that left ventricular remodeling. That is why we are putting it in cardio selective. Okay, so that is non-selective and selective one way. Now there are certain beta blockers with partial agonist activity. Okay, so that is known as intrinsic sympathomimetic activity. Okay, which are these? So again you remember one mnemonic, contain, here O you write big, partial agonist activity, contain partial agonist activity. Okay, so what are these? We have C, celiprolol, ठीक है, O, oxprenolol, then P, pindolol, then A, ace-butalol, and again A, alpranolol. Okay, so these have partial agonist activity. Now why do we need partial agonist activity? Okay, selective I can understand, you are using cardio selective, so they will act more on the heart, but remember if they are given at higher doses then they can also have this beta 2 activity, so dose is important in that. Anyway, so I was telling, yes, cardio selective are there, we can use more for the cardiac uses. Okay, but why do we need partial agonist activity? Because some patients are prone to excessive bradycardia. So when we give cardio-selective drugs as well, then heart rate may decrease too much. Okay, so in that case, these partial agonists can be given so that they stimulate the same receptor as well. Yes, they are blocking and they are stimulating as well. So they are given in patients in which the patients are prone to excessive bradycardia, right? So that's why we need to remember beta blockers with partial agonist activity. Now there are certain beta blockers with additional vasodilator property. Understanding? We have seen that beta blockers are causing vasoconstriction, but we are telling here beta blockers with additional vasodilator activity, and these beta blockers, these are known as third generation beta blockers. What are these? We have labetalol. Okay, then we have celiprolol, carvedilol and nebivolol. Okay, so there is additional vasodilator activity. So we see in these basically labetalol is beta 1 plus beta 2 plus alpha blocker, and this carvedilol also beta 1 plus beta 2 plus alpha blocker. Okay, so it is blocking first of all other sympathetic activity as well. So we can say these are alpha plus beta blockers, and because of this alpha blocking activity they are having this vasodilator property, because alpha receptors when stimulated it causes vasoconstriction, right? So that is there. Labetalol also has beta 2 agonist activity, beta 2 agonist. Okay, so that means can it be used in asthmatics? Yes, beta 2 agonist means now bronchoconstriction is not going to be there. Okay, so that is important. Then celiprolol also, it has beta 1 blocking activity, it is cardioselective, plus it is beta 2 agonist. Okay, celiprolol. So these two, labetalol and celiprolol, they have beta 2 agonist activity as well. Nebivolol is beta 1 blocker plus N for nebivolol, N for NO. It can release nitric oxide as well, and that is why with nitric oxide release it has vasodilator property. Understanding? So these various drugs, various beta blockers have, apart from the beta blocking activity, they have vasodilator activity. Then we have alpha and beta blockers together we have, which are these labetalol and carvedilol. Carvedilol has antioxidant property as well. So some properties of different beta blockers you should remember, right? Then there is this timolol. Timolol we have seen, O2Z. It is used for decreasing aqueous humor in open angle glaucoma. Why? See, there are certain beta blockers with membrane stabilizing activity. I told you, right? This membrane stabilizing activity, it is used in arrhythmias because we don't want too much excitability of the membrane, right? Excitability means RMP should not go up. Membrane stabilizing means it will remain at resting membrane potential. It will not excite too much. So there is decrease in the automaticity in the heart, and such kind of beta blockers are used in arrhythmias. But this timolol is the one which is not having any membrane stabilizing activity. And why it is important? Because that these beta blockers, they also anesthetize cornea, and that can be dangerous. We don't want the cornea sensation to go away, okay, because it is dangerous. Little bit injury, it can lead to damage to the cornea, okay, so we don't want that. So timolol is the one which doesn't do that, and that is why it is used in open angle glaucoma, right? So what are these beta blockers which have membrane stabilizing activity? Yeah, there are too many, but I have tried to give you mnemonics for each of them, right? So there is some overlap. We see that okay, cardioselective means we have carvedilol here also. Partial agonist means some have been picked up from here, some have been picked up from here, right? Similarly, in membrane stabilizing, different beta blockers from different categories we will pick up, and we will remember one mnemonic, that is lamp square. Okay, so membrane stabilizing, we have lamp square. Simply lamp stabilizes the light. MSA, there is membrane stabilizing. So what are these? We have labetalol, acebutolol, metoprolol, pindolol and propranolol. Okay, labetalol, acebutolol, metoprolol, pindolol and propranolol. So P square is for 2 P's, right? So that were the various beta blockers, their uses, their adverse effect, contraindications, and what are the various beta blockers in various categories. Thanks for watching the video. If you liked it, do press the like button, share the video with your friends, and do subscribe to the channel Physiology Open. Thank you.